Well, hello. I'm Dr. McIntosh, and it's just a tremendous privilege to have you all join us today as we continue our study into the pain pathways. I am greatly privileged to have Dr. Mormon Lee with me here today. She's a clinical associate professor and assistant director of pharmacotherapy and translational research. But really the main issue is she's been working for the past 20 years or so in the ambulatory as well as the long-term environment with pain. Her passion truly is pain, and you'll see that today as we discuss our cases, as we look at the information that she has provided. So I'm really excited about having the opportunity to interview her. First of all, I'd like to just give a very brief summary of sort of where we've been so far. First of all, we sort of discussed a little bit about acute pain versus chronic pain. Obviously, acute pain is when I have a patient who comes in the emergency department. He's fallen perhaps and broken their leg. And we expect in that situation, as soon as that leg heals, the pain resolves. However, in chronic pain, quite often what happens is when that person's potentially healed or it becomes more of a chronic issue, then the pain persists, and the pain persists perhaps for greater than 3 months. And when we have the pain in this situation, there are multiple modalities of pain or different avenues that we experience. And for example, if you have back pain, we know that the more back pain you have, the more inflammation you have. The more inflammation you have, for example, the more spasm you have, and you get sort of in this horrendous cycle. And we talked a little bit about the amplified pain syndrome. And we've talked that there are pharmacologic interventions that we may need, but there are also non-pharmacologic interventions that are extremely important as far as dealing with pain. And today, once again, we're going to get into both, because we have our expert here that's going to give us a real idea how to approach pain, from a team standpoint. So I'm really looking forward to the discussion. So let's hop right into it. And, we talked about the whole team approach. Dr. Lee, sort of tell me how we might utilize the team to deal with these different aspects of pain, the acute pain versus the chronic pain.
Okay. So basically, we started here with this tool belt on the screen here. And I think if you think about when you're remodeling, for example, all these tools come in and really are effective in different areas. And I think when you start thinking of our different team approaches with all the different expertise that we have, you're going to find that each of our providers, depending on what areas of expertise, can really help in terms of managing that pain, just like our tool belt.
Oh, that's a great explanation. I'm remodeling my home right now, and we've just torn up the whole place. So it's painful in all kinds of different areas, and I'm hoping the electricians and the plumbers and everyone is going to help me get through there. But let me take a look at, I think it's a good review, the different sort of modalities of the different sort of background of pain. I know we have different types of pain, but when we get chronic pain, we need to sort of address each one of those areas. So if you could sort of explain to us once again, the different types of pain and how they might manifest, that would be really helpful.
Absolutely. So as you see on the slide here, we have different types of pain that I think it's really important to recognize, because the treatment approach is going to be different as well. Mm-hmm. And so we have the musculoskeletal pain, and I have a lot of common pain issues that you'll see there. Osteoarthritis. Not only is it musculoskeletal, but sometimes we can even see a neuropathic component of it. And so when you're working with your providers, they're going to be asking a lot of questions on, what are you feeling? So are you feeling a burning pain? Are you feeling a stabbing pain? And we're going to talk a little bit more about that. You move into rheumatoid arthritis, predominantly you're thinking of your joints, but there's other things that are associated with rheumatoid arthritis that can cause pain as well. And so we're looking at that. vertebral compression fractures, chronic back pain. All of these can cause both the type of muscle pain, the bony pain, but also some of that neuropathic pain as well. So then we move over to the neuropathic pain. That's where I always tell my patients, your nerves communicate to your brain with different types of signals or different types of pain. You'll feel burning, tingling sensations. And that's how your nerves say, I have damage, something's wrong. And so you see that folks with diabetic peripheral neuropathy, they have that burning, tingling pain. So an example, if you've never had anybody that's experienced this or explained it to you, or if you haven't experienced it, think of a time maybe when your leg fell asleep and your leg, starts to wake up, you feel that tingling sensation. That's a similar way that a patient might describe what they're feeling with diabetic peripheral neuropathy. Again, their nerves are damaged from that high blood sugar, and so those nerves are sending the signal to the brain saying, I hurt, burning pain, tingling pain sensations.
Yeah, so I can sort of see that. Several years ago, I was riding my bike in the dark and got ejected off the bike and did have a sort of a compression fracture, but it really wasn't, I don't think the fracture that was hurting me as much, it was that I was getting radiating pain around the right side of my ribs. So that was more of a neuropathic. Obviously, I had muscular pain, but it was the neuropathic pain that was really causing the problem. So we need to hit that in several different areas. So, give me a little idea how you would approach that, all the modalities that you're sort of bringing together.
Okay, so when we're thinking about these different types of pain, there's going to be different ways that we treat it. And of course, as you see on the slide here, I have pharmacotherapy. So we'll talk a lot about different types of medication. Physical therapy is vital with different types of chronic pain situations. A lot of times when you hurt, what do? You want to lay. So with that bike situation, you were in pain. The last thing you want to do is move. Because that makes it hurt worse. And what happens is your body will start to decondition. And so those muscles get weaker and weaker, and our muscles are there to protect us as well. And so physical therapy comes in and they teach you the exercises that are safe for you. So during that rehab time that you had with the bike accident, there are certain exercises that were probably appropriate for you, but other exercises that were not. And that's where physical therapy can really come in. Also, there's complementary methods out there in terms of acupuncture, for example, that is shown to be very effective in certain types of pain conditions. And then with biopsychosocial models. And so when you had your bike accident, for example, did you feel a lot of stress during that time?
Oh my goodness. I mean, every time, I wanted to work and I was working, but when I'd go into the emergency department, the stress at work would tremendously bring out, the pain that I was experiencing.
Absolutely. And that's something that we talk to our patients a lot about, is how the stress can really impact that pain. It can make it go a lot higher. We don't breathe appropriately. When we're stressed, we breathe a lot more shallow. And again, this is all very important. It also can affect your sleep. When people hurt, people don't sleep. And so that increases stress. So you can see how it goes round and round and round. And so we've got to develop different types of tools on how to recognize when you're stressed, how it's affecting you, and then what are those tools that you can use, such as deep breathing techniques, guided imagery, all of the things that can calm the system down so that you can start to relax it up and decrease that stress so you can heal.
Okay.
Self-management, how do you take care of yourself? And education, again, doing this and getting to know what types of chronic pains are out there, what can we do other than just taking a medication. Medications can help, but all of this works together to get a better control of chronic pain management.
Wow, and let's put it in this situation. I have a patient in the emergency department, and quite often they will come back because they truly have pain. And we talked a little bit about the amplified pain syndrome, but let's just say, for example, I have a patient who has chronic pain. They were involved in a motor vehicle accident, let's say 6 months ago. We know they aren't candidates for surgery, for example, but I need to set up a treatment plan for them. Yeah, I may, give them some relief at that moment, but I know I can't stop their pain. So if I refer this patient to you, when I refer this patient, can you tell me sort of what it would look like? What are they going to experience as they go through your team approach? I just love this approach. It's fantastic.
Okay, so it's really important, first of all, that we do a proper assessment.
Okay.
Because as we just talked about, all these different types of pain issues can have different types of pain worked in. So we call it a mixed pain presentation. So when we're doing the assessment, we're asking tons of questions about what are you feeling, what types of pain, how does it affect you, where we ask for pain rating, but we're really looking at function. And that's huge because if we can get you moving better, everything's going to help get it better in regards to the stress in terms of the deconditioning, all the things we talked about. We'll be asking you in regards, how do you sleep? How are you waking up at night or having trouble falling asleep at night? All of those things are very, very important. Also looking what kind of substances you're using. Are you smoking? And so then we're moving to the non-pharmacological treatments, finding out what you've done in the past. So some people think that those don't work, but they really do. But we have to figure out what you've tried, how long you tried it, and if they work.
And did you do it correctly?
Exactly. And so each one of these start to work together to add, as we get to non-opioid options, of course, we're asking you, have you taken anything over the counter? And then we need to know, how are you taking that medication? Because that's very, very important, because sometimes it could be that you're using too low of a dose or just using it once or twice a day, where it might need to be dosed more appropriately. So it might not have given that effect. Or if you had a bad side effect from a medication, was it started too high of a dose?
Okay.
So we want to make sure that we're not eliminating some of those treatment options.
And so, I mean, if you have an elderly patient, that's going to change the medications that you may potentially use
Absolutely.
versus others.
Absolutely. Or if your kidneys aren't working as well.
Right.
There's so many different things that we're looking at, and that all goes into that big full assessment. So if you ever feel like we're asking so many questions, we are, but they're all pertinent, and that really helps us develop a better treatment plan. And that brings us to those adjuvant options you might have heard of, like gabapentin or Lyrica or pregabalin. Those types of medications we're looking at to help with the pain. Then there are times we'll look at opioid management. Some patients are good candidates for opioids, some are not good candidates for opioids. The thing I want to stress is that opioids can be very dangerous on many different levels. And so it's very, very important that we take a full look at if it's the proper step to move to an opioid therapy. I will tell you, though, that all these other things we just talked about are better to try first before we go to that opioid because of the risks associated with opioids.
Yeah, and we all have heard so many problems that we've dealt with the opioids and, you know, people, and I see it in the emergency department, the side effects and problems that we run into. So that's so important.
Absolutely.
Well, good. And, you know, just taking a look at, I would sort of like some of those adjuvant therapies. Let's just sort of delve a little bit, you know, into the, you know, starting with some of those non-pharmacologic therapies, or the non-opioid therapies.
Okay,
So
non-opioid.
yeah, the non-opioid therapies that you, you know, as a pharmacotherapist would utilize, and then you're bringing in sort of the non-adjuvant, you know, the other non-pharmacological interventions
Sure.
as well.
So as you see on the slide here, I've given you some examples of some things that can be used out there for musculoskeletal pain. And so I've given you some examples that we already talked about a little bit of what types of pain that we see with musculoskeletal injuries, and then the description of it. There's some examples as we talked about. But as you'll start to see here, we use Tylenol or acetaminophen. A lot of patients think, well, that's over the counter, so that's not going to help. It's actually very helpful in some situations, but every drug has its risks. So we have to take a look again at what's going on with your liver, any other problems or drug-drug interactions that we need to worry about. Now, I will tell you that topical analgesics have gotten a lot more love lately.
We're using them, and I'm loving them, let me tell you.
Absolutely. The nice thing about these is they don't have a lot of absorption into the body. We call it, you know, systemic absorption. And so that's nice because we don't have to worry as much about kidney or liver or any drug-drug interactions, although there could be some. So again, we have to be careful and analyze everything. But I've listed some for you. So one example would be Bengay, which these are counter irritants. Then we have the Aspercreme capsaicin we use for nerve pain a lot of times. The one thing is you got to be careful how you're putting that on, because if you get it in your eyes or your nose, it's going to burn.
I've had a patient do that, and it's no fun.
Not a good idea. So it's important that if you're going to use some of these topical analgesics, you can buy them over the counter, but please reach out to a healthcare provider to know exactly how to use them correctly. So going on to your topical NSAIDs, we now have diclofenac gel over the counter. Actually, it was Costco the other day. You could buy 3 tubes of that. at Costco, over the counter. But what that is an anti-inflammatory gel that's been really effective on osteoarthritis. So if somebody has bad knees, it's beautiful because you can put it on the knees, you put it on 4 times a day, and it actually can decrease some of that inflammation. Now, what's the difference between that and your systemic NSAIDs, something like ibuprofen, for example, that you buy over the counter? Well, the difference is that the topical is more local. You don't have very much absorption. Where you take that pill, it's going to the body and you're absorbing into the system. So that's going to have a lot more implications in regards to your kidneys or any other side effects like your stomach and even heart issues. So we have to be careful there.
Yeah, great example. My 89-year-old mother fell, she broke 8 ribs. But in reality, she only used opioids for about 3 days. And we did muscle relaxants on her. We used some neuropathic type medication intervention and that lidocaine patch. And then we added, some Tylenol, and a little bit of Motrin. She's older, which is a non-steroidal, but we got her through that. It was unbelievable. So I'm wholeheartedly a believer in this sort of multimodality approach.
Absolutely.
It works, let me tell you.
Absolutely. And I think, back in the day, we all thought, oh, we just need to do opioids for an extended period of time. And that's not true. We can see, just like with her case, short with an acute pain issue, that's perfectly fine. But a lot of these drugs work together as a team to really help treat the pain in general. So moving on, and one thing I did want to mention is duloxetine. It's kind of an interesting medication because it has a little antidepressant effect, but it also works to help with pain. And so that's a medication you might hear about. The brand name is Cymbalta, but we utilize that a lot as well.
And we know when you're in chronic pain, you do get discouraged, and many of our patients are depressed because they can't work, they're having financial issues, and I can see where that would really be helpful.
Absolutely. And again, going back to those self-management skills as well, because I think we have to look at what can we do, even with the limitations. I always tell my patients, you have a decision today. Either you have pain or pain has you. So which way do you want to go? And so that's something that we work together on to identify what they can do. Now, moving on to internal organ pain, this is like that viscera pain. It's a very difficult pain to treat. This is where somebody might have that belly pain where you could have endometriitis, appendicitis, but it's more of a referred pain. Mm-hmm. And so you'll see that there's some different agents that are used there. Tylenol helps maybe a little bit, but not that great. But you will see some of these other ones that you might recognize. Tricyclics, for example, amitriptyline is a common one that's been used, gabapentin, and of course, sometimes they have to move to those opioids. So I think it's just important here to know, again, that there's different types of pain, and so there's different types of treatment. There are overlaps with that, but you have to be aware of what kind of pain we're dealing with.
Okay.
And that brings us to neuropathic pain, like we talked about. That's that burning, tingling, shooting
and that's
pain.
The one that's coming from the nerves, sort of a
nerves.
wire that came around my rib here,
Yes.
that nerve or that electrical wire, and it was irritated, obviously,
Absolutely.
and it was hurting.
And it's not just those experiences. I had a patient one time that she would sit there while I was interviewing her, and she was wiping her legs because she felt water dripping down her legs. Her legs were bone dry, but those were her nerves sending that sensation to her brain saying your legs are dripping with water. And so that, again, people experience things a little bit differently. But in general, most patients will say burning, tingling, shooting pain.
And it's sort of that pain, someone has degenerative back pain and they have that shooting pain down the leg, the sciatica type pain.
That's right. We also call it radiculopathy.
Right.
And
exactly.
so radicular pain. And so when we hear those kind of symptoms, when we're doing the assessment, we'll think towards these types of medications. And again, you see tricyclic antidepressants there, gabapentinoids, and then your SNRIs. And so again, you see those overlaps, but these types of medications, as I tell my patients, it almost turns the volume down. So imagine you're listening to the stereo and this horrible song comes on that just hurts your ears, but you can't turn the volume down. So your ears are just banging from this awful music. That's what neuropathic pain is doing to these patients. So these come in and help through different ways in the body to turn the volume down. Can we eliminate the pain? Probably not, unfortunately. We don't have that magic pill out there, but this can help decrease it so that we can get busy living.
So we're sort of turning the dial down, doing sort of a different reset, almost like your, the air conditioning in your home. You're turning it down to 72 rather than, leaving it, 78.
There you go.
For example.
Absolutely.
So that's, I mean, that's really positive. In fact, you've got back pain, for example. We're looking at, for example, the musculoskeletal component. You're using medications, non-steroidals, but obviously there's a neuropathic component. There may be swelling as well that we may be using some other things. So that's a great example, bringing all of those things in. But let's move a little bit into what are the other type of things that sort of non-pharmacologic, because I know they can be so helpful. So tell me how you're using that as a team and bringing that in to help our patients.
Absolutely. So as you see there listed, there are so many different things we can use. And so this is where that team approach comes in again, because we have folks that can do the physical therapy assessment, training on exercises. We can have pain psychologists that can help teach various types of biofeedback, self-hypnosis. There's different types of distraction. Music therapy has been shown to be very effective. It's almost blocking some of those pain signals to your brain because you're doing something else. And one thing I always talk to my patients about is, so when is your pain the highest? Is it during the day when you're busy and interacting with people, or is it at night when you're laying there and you can focus on it more? And 9 times out of 10, they're saying, always at night. I can just really home in on it. And when you think about that, at that time, we don't have all this stuff coming at us. We have time to really focus in on what hurts. And so those signals are getting through more. I always say, well, the train tracks are completely open. But any of these types of things, or life in general, can help block some of those train tracks or those signals to the brain. And so that can really help. And so a lot of patients will say, oh, I don't know, I've tried a couple of these, but some of them work for some people. Others, it works great for. It just depends. So not only do you have to give it a try and really believe that it'll work, but you got to give it some time too. So you got to keep practicing it, mastering it. So meditation, for example, how do you clear your mind and really work to decrease all that stress in your body through that process? So all those types of things are various effective models, but again, we have to be patient. So it does take time.
So this is real. Now we're moving, it's not a pill for every ill, but in reality, we're talking about personalized medicine here.
Yes.
Meaning you're doing an excellent history to find out what are the different sources specifically of your pain.
That's right.
And then you're selecting what modalities may best work for that person. So if I have my, worker, big construction guy comes in with his back pain, he may not be doing yoga, but he may. I mean, it really depends. So then you have to work with this guy to see what really will he do, and how he'll respond to that. So it's that whole personalization that we're bringing in. So it's the pharmacologic and the non-pharmacologic.
Absolutely.
That's just great.
And as you see up there, there's a picture that is the TENS unit. And when I first started my practice, these were $300 or $400, and we couldn't reach those. But now, if you go to even Amazon, you'll see that they're like $25. And so these can be very effective. Also, some patients might like to have that control. And this you would adjust based on what the pain is. So you just have to use it appropriately, but it does give you that sense of control. It's something that's a little bit uncontrollable in regards to.
And it's sort of breaking that pain pathway.
That's right.
The one that's running up, and it's that pounding you're talking about, when the volume is just turned up too high. So you're trying to intervene.
That's right. Or block your train tracks.
Right. Block the train tracks. I wonder, when I go run, I feel like I'm in pain, but if I do put music on or something when I'm running, it really does have a tremendous impact. So it's sort of that same concept as well.
Absolutely.
Now you mentioned something about a breathing exercise, and I'm really sort of interested to see if you can help me, because I'm sitting here even with a little bit of stress because we're trying to get through this, but also my back, it's always sitting there. Can you teach me anything that'll help me just right now? I want to deal with it.
So we have the deep breathing techniques that take a little bit longer, but one that I've learned recently is this short, quick thing that where you maybe feel that stress like you're feeling now, or maybe you're in a meeting and things are just like this, and it's called the physiologic sigh.
The physiologic sigh. That's interesting.
So basically what you do is you breathe through your nose twice deep.
Okay.
And then out. So
I'm going to try that. You need to shut your eyes or anything like that,
No.
or just better? So I can even do it when I'm driving.
You can do it when you're
Okay.
driving, you can do it in a meeting.
So I just do 2 deep breaths in.
2 deep breaths in and then out through your mouth. So hopefully you're trying that at home as well. But this just centers you. And it starts to calm everything down. Do you feel calm?
Yeah, I can feel that, absolutely.
So another way I read about it was when you feel like you're really frustrated, you're getting ready to say something you shouldn't, do
Okay,
the physiologic sigh, because it gives you that pause to make your brain stop, think before you talk. And
okay,
I thought, that's fantastic. What a great tool. And so I've been having patients practice this, and they say, I really can just feel kind of that type of pause, relax, and I can move on. So
Yeah,
it's
I
that
can-
little restart.
yeah, I can see, when you're extremely stressed, you sort of go in that fight and flight mode. And when we're doing that, it sort of turns off our thinking part of our brain. But if I can do that little technique, the physiologic side, it will sort of break that, that fight and flight response and allow me to think and not say what I don't want to say. So I like that. Very, very good.
Absolutely.
So one of the next things I know everybody wants to know, obviously the opioid component, we do need to address that briefly, because that really has an impact not only on our family members, it has an impact on our fellow workers and that type of thing, and it's impacting our lives daily. So bring me up to date a little bit about what's going on with the opioids and how we're trying to control it and do a better job as doctors. Because, I am cutting back my prescriptions, but I need to give something to my patients that I really can help them. And that's where the sort of multimodality approach is going to help.
Absolutely. So we've had this opioid epidemic. Unfortunately, we have a lot of overdose deaths out there. I do caution you on these numbers, though, because you have to remember it's usually going to be polypharmacy with the overdose, and it's hard for them to tease that out sometimes. But the bottom line is we have a problem with opioids out there. There are people dying from opioids, and we talk about that risk versus benefit. And there's a lot of things with opioids. It's not just taking too much. There could be drug-drug interactions that lead to higher levels of opioids. It could be combining things such as substances like alcohol that can increase the risk, or things called benzodiazepines like Valium, for example, that can increase risk. So that's something we have to think about. It can be accidental ingestion, meaning that you didn't realize it was an opioid. Maybe a child gets a hold of it.
Exactly.
All those types of things can contribute to this, but we have to be careful too. There are patients that are good candidates for opioids. We know that. We have to be careful of that pendulum. For a while, we were very comfortable in saying, everybody, opioids, right? That was something 20 years ago, basically. Now, as we've learned more, we've seen the problems. The problem is that sometimes we tend to shift clear up to the other part, and we don't want to do that either. That's where that assessment comes right back, that we have to look and be very careful, utilize all other options, and then say, okay, we've exhausted these various things, and yes, we're going to use opioids in this case. Same with acute pain, for example. There's going to be times that opioids are appropriate, but I think it's important as a society that we recognize the dangers and how many people that are dying from these deaths. And you see the trend's been going up and up. By 2018, though, we're starting to see a little decrease. So that's kind of exciting, because I think people are really starting to recognize that. And it takes everybody. It takes the doctors. It takes the patients. It takes everybody to realize, one, we have to select correctly, but we got to keep them locked up and make sure they don't get the wrong hands.
And I know we have about a minute left, and I know there are some things that we can do to protect our families. And I know there's something called naloxone. Tell me just a little bit about that, and that'll be our last topic.
That'll be it.
Great.
So basically, the first thing is, as you look here, there's a new dealer in town. This was a great slide created by Joe Camilleri. And so this shows you that we have to think about how we get access to opioids. And a lot of times it's sitting in our house. So the other thing we could do is use naloxone, which is a way that we reverse the effects of opioids. It comes in a lot of different formulations, but it can come intranasal, so the Narcan nasal spray. There's an Ezio that's an injection, and it actually talks to you and tells you about it. But there's other ways they can do the injections and also IV. So I put the two in red, those you could get over the counter. You could actually, well, not over the counter, you could go and talk to the pharmacist and you could actually get it even without a prescription. They have a way of creating a prescription for you if you have any opioids in the house. And we feel it's really, really important. If you have any way that somebody could be affected by opioids, then it's really important to have a Narcan in your house. The nice thing about this is it can't be abused. And it has no effect on somebody that's not taking opioids. So if you think somebody's down from an opioid overdose and you administer the Narcan, you're not going to do any harm to them.
Oh,
so that's
okay.
really, really important. So it's important to have this in your house.
All right, well, we have somebody there, we need to get it.
That's right.
Absolutely.
I call it the gift of time.
The gift of time.
Because you have to call 911.
Right.
Because we got to get EMS going and get the Narcan in, and then they'll be there to follow up and take care of the patient.
That's fantastic. Well, thank you so much. Wonderful, wonderful discussion. So just in summary, the things I've learned today is that, chronic pain, the underlying issues that bring about chronic pain are multiple, and it impacts on our entire life. But you have a team that actually a team approach in order to intervene, and it uses pharmacologic interventions, non-pharmacologic interventions. There's many things that we can do to sort of rewire our brain. So, this has been really helpful, and I hope it's been helpful to you all. I know we're running right to the end of our time, so feel free to ask any questions. Just send it to the wellness team, and Dr. Lee or myself will reach out to you and get those questions answered. All righty. Well, thank you so much, Dr. Lee.
Thank you.
Really appreciate it. Thank you all for joining us.